will make a start. Welcome everybody to public board today. And if we've got any members of the public, welcome in particular to yourselves. I'll just run over the sort of the basics in terms of apologies and then a little bit about housekeeping and so on and so forth. We've obviously got elections going on today, but for sort of County Council and Police and Crime Commissioner, in spite of that, I believe we will be quorate. We have had some apologies. So we've had Melanie Brooks, and I see that Jonathan Gribben, who was going to represent, in fact, we may not be quorate as apologies received. Oh dear. Well, that's a problem, isn't it? But I think Jonathan Gribben was going to represent Melanie, but I'm not sure we've got anybody representing at all, but we'll come back to that. Councillors Tony Harper and Kevin Rostons and Mel Barrett is not able to attend either, but Catherine Underwood will come as a deputy from 4:30. And we expect Rosa to arrive at 4:30 as well. So if we're not quorate, I think we just have to think about that in terms of any decisions we make. We'll probably have to bring them back to the next meeting for ratification, but hopefully we can kind of move along with most things, in terms of actually holding the meeting. So it's just one of those tricky days, isn't it, that we happen to have landed on. So I hope that's okay. Everybody will be on, no doubt, on mute. If you want to speak, I think you probably have a raise hand function, or you can pop something in the chat, or in desperation wave frantically at the screen and hope you appear in front of me. But I will try and bring you in from one of those methods. So in terms of the membership of the overall board, I do want to just sort of mention there's a few comings and goings, I think is fair to call them. So you'll recall that Lynn Bacon retired on the 16th of April. And obviously we've wished Lynn a happy retirement and thank her for her long service. But on behalf of the board and her role at City Care and as People and Culture SRO, I would want to say thank you on our behalf to Lynn. You will probably also know that John MacDonald is on a secondment to the University Hospitals of Leicester at the moment for a year, and we have Claire Ward is his deputy and is here indeed today representing Sherwood Forest. So that's good, thank you. And Jonathan Hart has stood down from his role as the City PCN Clinical Director and no doubt will continue his work as Chair of Nottingham City General Practice Alliance. And then Councillor Eunice Campbell-Clark, she stepped down from the ICS Board as she's no longer portfolio holder for Adults and Health. And Adele, who I'm sure I've seen on the screen somewhere, Adele Williams, is now the portfolio holder in a combined role for Adults and Health and Chair of the Health and Wellbeing Board. So thank you, Adele, for being here in all those capacities. And as we've had some changes and people coming and going, we've got a few people to welcome. So Louise Bainbridge is the incoming CEO for Nottingham City Care Partnership. So welcome to Louise. Claire, I've mentioned from Sherwood, and then we've got Dr. Mike Crowe, who's the new representative on behalf of PCNs in the City ICP. So hi, Mike, I can see you on the screen as well. Fine. So I think hopefully I'm looking, where am I looking? Rebecca or Amanda or something. And is that complete the sort of roll call at the start? Yeah, fantastic. Next item is conflicts of interest and register of interest. We refresh these every 6 months or so, and I understand there's been no new additions to that. Does anybody wish to declare anything relating to today's agenda? Paul.
Thanks, Kathy. It's not in relation to today's agenda, but just to note that on the register, I'm now no longer chair at Lincolnshire Partnership, having finished my second term there. Thank you.
Well, yes, thank you. And I know you did send something through on that, so thank you for updating on that one. But otherwise, we'll take that as it is. Fine. So we can move on. Is there another one?
Yes, Kathy, it's Dan. Thanks. Yeah, just wanted to flag that I have some to remove that are related to me no longer being portfolio holder for transport aligned with adults, alongside adults. So if I advise by email, which those are.
Perfect.
Thanks.
That'd be perfect. Yes. Yes. Otherwise, you have an impossible task, wouldn't you, to take on absolutely everything. So very good. So let's move on quickly. As somebody noted, we need to move at a reasonable speed. So let me crack on. Minutes of the 18th of February. Anybody got any matters of accuracy to raise from those? I'm hoping not, because they seemed fine. So we'll accept those and sign those off. The actions log, all of that is up to date. There's one action that I took around a future session on people and culture, and we are working to get that in hand. I think, again, I'm looking at Rebecca there. I think I understand that we're developing a plan for a plan there, really. And there's lots of things we'll want on our development agenda, of which that is an important one. We'll bring a work plan back to a future meeting so everybody knows what's coming up as we develop these ideas. So is that okay for that item? And then that takes us on to a really important part of our agenda. And I've got Alex Ball and Nicole Chavodra to introduce this, but it's our citizen story. And today, quite rightly and very pertinently, in terms of the work that's been going on in terms of vaccination against COVID-19, we've got a story about tackling health inequalities. And I think this should be really, really interesting and really pertinent to the work that we'll be taking forward beyond COVID, and what's the learning and so on. So Alex, can I hand over to you in the first instance?
Yeah, thanks, Kathy, and good afternoon, everybody. So yes, I'm Alex Ball. I'm Director of Communications and Engagement for the ICS, and I'm here with Nicole Chavodra from the vaccination programme. So I'm just going to give a quick overview of the health inequalities work of the vaccination programme and draw out how that's impacted on our citizens. But as you say, Kathy, there's a wider story here to be explored. So in terms of introductions, it's probably first important to note that the vaccination programme has really used data throughout its lifetime to really guide the decision making. So we knew straight away after the launch of the vaccination programme that there were differences in uptake rates within our populations, differences by geography or by affluence or by ethnicity, a range of variations there. So to tackle that, an inequalities framework was developed to ensure we really had the foundations of a response to that challenge, make sure that was in place. And then an action plan on top of that was put in place. And it's really important to note that was really jointly owned across the system. Input from NHS commissioners and providers, from the local authorities, from the voluntary and community sector organisations, a real partnership approach. And that plan initially focused on tackling the convenience barriers and also the confidence barriers that exist between people and taking up their vaccine. So firstly, on convenience, hopefully you can see a range of kind of images here of some of the different things that we've done. Firstly, to supplement the large fixed vaccination sites, we rapidly developed a GP practice-led set of clinics, offering the vaccine in a really local and familiar setting, and also really exploiting that trusted relationship between GPs and their patients. And then on top of that, we've run pop-up clinics in really trusted community settings, so mosques, churches, other community buildings, often also with really kind of appropriate staff for that community that we might be trying to reach to really provide endorsement and reassurance. And then finally, the vaccine bus has been running for nearly a month now, bringing the vaccine to communities in a really agile way, again, driven by data as to where the bus might park up. So convenience is really important. Making sure that people feel really confident about their vaccine choice is also a critical element of that. So some of the activity we've done in this space is the development of some how-to guides to really enable community groups to support vulnerable or digitally excluded residents to book their appointments. We've made sure we've been on Kemet FM, Radio Dawn, the local community radio stations that really reach potentially communities that are at more of a distance from their vaccine. We've used and promoted BSL and Braille materials to make sure that members of the deaf and blind communities are really included, and we've made sure that materials are translated into many languages other than English. And an important part of what we've done has also been a range of videos, and I'll show one in just a minute, featuring trusted community leaders that really can promote the vaccine. And all of this has been supported by a regular programme of community briefings, attracting hundreds of VCS and other representatives, as well as a number of targeted sessions really tailored for different communities, different languages, different contexts. So how's this felt for people? So I've just got 2-3 kind of case studies of how this impacted. So we can see here, I can hear from Hamid, talks about his feeling of kind of collective responsibility in getting the vaccine, which I think is really interesting. But at that same clinic, we met an 80-year-old lady. She'd refused to get the jab at one of our main vaccination sites. Even when booked in by her son, she just didn't turn up to those appointments. But when she learned that the vaccine was being provided at her mosque, had been endorsed by the imam, she was there. So I think there's that real kind of trusted broker. It's a really important element. Dr. Alawale here, he's been able to combine his leadership role in the Black community with his role as a GP, giving real confidence to the establishment of another pop-up vaccination clinic. And then working with really trusted organisations, advocates like Framework has been really, really valuable, supporting service users to come forward for their jab where otherwise they might not feel quite so confident. And then I really like this quote from a member of Dr. Atkinson's practice, really kind of underlining that sense of trust and convenience and personal contact that really makes a difference for people coming forward for their vaccine. So I'm just going to quickly switch my sharing, if that's okay, and play just a minute or so's video of one of our residents talking about their experience of the vaccination that we've used to encourage others, and then hearing directly from a member of the South Asian community about their experience with the bus. So hopefully we can quickly play this and the sound will work.
Hi, Marie McGlinchey. I'm 51 years old. I'm in the extremely vulnerable category, having stage 4 bowel cancer. Today I went for my vaccine after having the letter last week. It was easy to do, to book online. The place where we went to at Kings Meadow at Lenton Lane was absolutely fantastic.
Hi Piyush, how are you doing?
I'm good, thank you very much.
Good. What was your experience here? How it was overall managed?
Well, the experience was fantastic. The queue is very well managed. In fact, it's not very busy at the moment. So I got my turn within 10-15 minutes. The vaccine process in itself is fairly simple. They took my details and then I was vaccinated in 5 minutes. It's an effortless process. And I would urge anyone who is watching, absolutely, to get the vaccination done.
Absolutely.
So that's just a couple of examples of some of the videos that we've used to really encourage members of different communities to come forward. So to summarise, I mean, the work here we've done, it's not perfect. There's lots more we're going to do and can do, but I do think it gives us some interesting pointers for the future. So in particular, the way that the programme has been really data-led, I think is a critical foundation. We have worked really hard as well to make this a partnership operation, so really drawing on expertise wherever it lives, within the NHS, within the local authorities, within the third sector. And I think the agility that the programme has demonstrated, really learning as we go, adjusting plans, has been an important signature as well. So that's all I want to say. People hopefully will have seen the longer report in your papers as well. And I'll hand back to you now, Chair. Thank you.
Well, thanks very much, Alex. I don't know if anybody's got any. I thought that was great to see, and it's really good to hear from people who actually had the vaccine, isn't it? It brings it alive, really. Anybody got any comments or questions on that, on what we've just seen and heard? Anything at all?
You've got you've got Tilan, and then you've got me, Kathy.
Oh, sorry. Right. Okay. Go ahead, Tilan.
Thanks, Kathy. So first of all, Alex, thank you very much for that presentation. And first and foremost, thanking the staff who've been really keen delivering such an effective vaccination program, and equally thanking the members of the public for the uptake as well. I think that in terms of, while we can acknowledge the success of this program, I would probably not necessarily adapt, but just going back to taking us back towards December and January, when we started looking at the data on uptake, we did have some challenges. And rightly so, Alex, right at the end, you mentioned about the agility. The reason I'm bringing this is, come September, it's very likely that we might need to think about a booster vaccination, and there'll be another wave of this. If we look at how our data compared initially in the very first few weeks, there was a bit of a disparity among access, particularly among the areas with greater deprivation and health inequalities. Around September, October, November, with winter and flu season coming, we probably would not have the luxury of time, and the lessons which we've learned now needs to probably be, our planning should be very cognizant of the challenges we faced around December and January, so that while we are agile, we start off with the lessons learned from the current vaccination program, and equally not surprising that from the full report, the value members of the public have seen in having a vaccination program driven and given at local GP surgeries, because that is the first, easily recognizable focal point of contact within neighborhoods. And we need to start thinking about how we use that as the fixed estate in the neighborhoods to really deliver the booster vaccination program at pace. But once again, thank you very much for everyone's efforts.
Thanks, Dylan. And I think there's some clear messages, isn't there, around how we take the learning from this. And I would urge us that we take the learning beyond vaccination as well. But certainly we can expect to do a third round. How that will be done, I don't know, but it sounds as though we should learn. I'll take two more points on this then. John Towler and then Nicole Atkinson.
Thanks, Kathy. So I'll be quick. I just wanted to comment first, which is to echo what Tilan said. It does feel as if this has been an incredibly effective programme and a huge team effort. So I think we should be immensely grateful to everyone involved. My quick questions were, there's a couple of points in the paper. First, about Nottingham City Council having an initiative to actually ring people up who haven't had a vaccination. So that direct contact. I wondered whether A, that was happening, B, whether it had been successful, and C, whether it was something we might want to roll out if it's working. And then the second question was around those are the BMI over 30 and whether we actually had any concrete, credible plans to address that particular group of people.
Yes, thank you. And absolutely, it'd be quite good to hear from, well, I guess Adele or anybody who knows whether or not we've actually been doing that. Because I had understood that there were councillors were actually ringing individuals, which is a very personal approach. So that would be useful to hear. Alex, is there anything you want to come back on to John on answering those questions?
So I'm going to pass to Nicole C, actually, because she's been really close, particularly that work with the City Council's contact centre. So Nicole, are you okay to?
Thank you. Yeah, the City Council have been doing follow-up phone calls to people who haven't accepted the offer of a vaccination, in particular those that are in the clinically vulnerable and clinically extremely vulnerable groups. I would say a small amount of success. It wasn't a hugely successful initiative, but what was particularly useful was that it enabled us to gather some soft intelligence about the reasons why people weren't accepting offer of vaccination. The nature of the staff that were making the inquiries was such that it wouldn't have been appropriate for them to have engaged in a longer conversation about the specific circumstances of the individuals that they were speaking to. But they were able to glean that for a lot of these groups, it wasn't a hard decline. And we know that for those in those groups that haven't accepted the offer, only 9% have actually declined. The others tend to want to wait and see what happens, how it affects other people, and are there any longer term consequences of the vaccine that might have an impact on their condition. So it was incredibly useful. One of the most effective means of engaging those who haven't accepted the offer, where there are concerns about their personal health, have been when they've had a conversation with a trusted clinician. And that issue about trusted relationships, I think, is the critical piece of learning that's come out of the work around inequalities, that there is phenomenal power in building networks of trust and influence through bilateral trusted relationships, whether that's with a clinician, whether it's with community leaders. It isn't a one-size-fits-all approach, and top-down messages are largely ineffective when trying to engage those that are hardest to reach. With regard to those with a BMI over 30, in addition to obviously extending invitations, which aren't always effective, they usually are, but the mobile vaccination unit is providing us with an opportunity to try things that we haven't done before. So as well as going out to specific geographical communities where take-up had been lower, both in a planned capacity and just popping up to see which works the best and if there's any relative difference, we're targeting particular communities with a shared characteristic. That's included going out to homeless support organisations, faith groups, but also employers. So starting from next week, we're heading out to some of the major employers of men, in particular occupation groups, and including employers that have a high prevalence of people from Eastern European backgrounds, who come from communities that we need to learn an awful lot more about what their relationship is with vaccination, why there may be hesitancy, and what are the types of things that we can do that will make it more accessible, convenient, and increase their confidence. So I think we're going to learn an awful lot more about how we engage some of those groups over the coming weeks as we start to move into the next stage of the outreach programme.
Thank you very much, really helpful. I'm conscious of time. I've got Nicole and then Adele. Just brief comments if you wouldn't mind, and then I'll need to move us on.
No, so I'll make sure I'm fairly brief. It was just three more comments than anything else. Agree with what Nicole just said around the trusted clinician having a very good hit rate when it comes to that kind of one-to-one conversations with patients. We've certainly found that has been invaluable. I think it's just really to say, yes, I think there's been lessons that have been learned through the programme, and you can really start to see it motoring and having that impact. I'd just really sort of be keen that we use this approach and translate it to our other, not just the vaccination programme, but a lot of our other work that we need to do as a system around health inequalities, in that kind of data-driven, using the community assets that we have to really target people, but also the bus, which I have to say, having been out and done a shift on the bus, that is a remarkable entity. So well done to everybody that's been behind the scenes to make that happen, because actually the cohorts of people that were coming forward are people that we don't normally see. So I think, again, if we can take that forward, not just for vaccinations, but other interventions, I do think that will pay dividends.
Thank you very much, Nicole. Yeah, very good. Adele.
Thanks. I really welcome those comments. I think, the important thing is that the local authorities are able to reach parts of the community that the traditional processes haven't worked, and what our colleagues in the contact centre were able to do is to reach out to those people and contact them. So I think I wouldn't want to diminish the value of that, because those were people who would otherwise be unvaccinated. So, they may not be huge numbers that were not caught by the previous process, but I think it's a tremendous value, and I welcome the comments around the sort of soft data impacts of that, of understanding what the causes of vaccine hesitancy are, and absolutely agree that's something we should take forward into our wider work as a system.
Fantastic. So really good comments from everybody. So thank you for presenting that. Thank you to the team and to everybody who's been involved. It's been a vast effort, hasn't it? Huge numbers of people volunteering, leading sessions and getting out. But I think some of the things we need to capture and take from this is that there are clearly lessons for us to learn about other forms of health and care from this, and it's almost, we didn't know, did we? We didn't know it was possible to reach people in this way, whether it's the bus or whatever. So I think we need to capture that. We need to make sure we always come back to it and remind ourselves of how successful this was, and therefore what else we might need to do, and the importance of those local communities. So a great exposition of just giving us a flavour really of the work that's gone on. So thank you to Alex and Nicole. That's wonderful stuff and sets the scene for our meeting, I think. So thank you for that. I'm going to move us on then to the next item, which is really to look at something that hopefully everybody's already had a chance to engage with. And that's the, originally we called it, I think, a partnership compact, but I think we've landed on partnership agreement. Hopefully everybody's, as I say, had a look at this, and you will see that there's two bits to the paper. There's the proposals around what this is, and then there's a summary, a small thing that we could use in our meetings and so on, in terms of how we engage together and do we meet our expectations. So I think before I open this up, just very briefly, I would say that it's clear there's been a lot of engagement around this, and thank you to those who've been able to take it through their boards and other official things, and recognise that that hasn't been possible for everybody yet. So this is a staging post. So those who still need to do that, you will be able to do it. Don't worry. Please do that, and indeed share it widely. Engagement in this is important. And thinking about that purpose and then how we're going to work together. I think we also need to recognise we are going to have to be quite robust with each other. If this is going to mean something, we're going to have to use it in reality, and we'll have to use it, you know, when we're having agreements, but we also need to use it when we don't always agree. And how do we make decisions under more stressed circumstances, and can we start to use this and so on. So we'll come back to all of that, but really just commending this to you. It has been through the system executive group as well, which I think was supportive. It's going to be dynamic. It may change over time, but some aspects of it we need to kind of pin down over the next little while. So can I open it up for any comments? I don't know, Amanda, if you want to kick off on this, or Rebecca, happy to hear from you if you've been involved in getting it together.
Just very briefly, Kathy, just to say that it's been great that people have been really engaged, and Rebecca's done a brilliant job, I think, of pulling together the comments. And I think it's, as you say, the intention would be that we build this into all of the work, the papers that we bring here and through the committees of the board as well. So we're sort of embedding this at every point of our work. Thank you.
Thank you. I've got Richard and then Tilan. Richard Mitchell, sorry, I don't know how many Richards we've got, just one, I think. Oh no, we've got several Richards.
Yes, I think there's a few of us
as well.
Yeah, good afternoon, everyone. So I'm Richard, I'm the Chief Executive at Sherwood's, probably like everyone else, full support for the paper and the principles. I think the view that we have is disagreement is really helpful, so we shouldn't be trying to ensure that we don't disagree. It's the way in which we disagree that can be dangerous or harmful. So it's about debating things, disagreeing, but in line with the values as described through here. It's the principles on the third page of the document that I think are key. The bit about being open, honest, respectful, and accountable. And I think tying into a point that you made, I think it was you that just made, Kathy. I think it will be really interesting how we respond the first time that we call out behaviour that is not in line with this document. Because if we find ourselves sort of 6 or 9 months down the line from here and we haven't referenced this yet, it suggests that we're not having the conversations in the way that this has been described. And my final point is, now I think we've got this in place, I don't think we should be trying to debate it or wordsmith it or amend it for months and quarters and years to come. I think we set our standard now and we move on from it, and we use this as much as we can do to manage the collective behaviours that we've described.
Thanks, Richard. Really, really helpful. I completely agree with you. My intention is that we do actually formally come back to it at the end of each meeting and actually ask ourselves, have we managed to have a discussion in that base? And I think you're probably right that if we haven't had to make reference to it, we've probably not pushed the boundaries of our discussions hard enough, because we need to do that. So Tillon.
Again, thank you, Kathy. Very much fully support this approach. My comment is more about the visibility of the page where, Kathy, you've signed, and with the partnership agreement. These principles are applicable as very much as it is applicable at leadership and board level for frontline staff, which have the interactions with various organizations. So this needs to be, the narrative needs to be embedded across all levels of our organization, tiers, or whatever we may call it. So that visibility clearly needs to be seen throughout our workforce. So whether it's just there for some captive phrases, and so everyone understands what system working or what does collectively working together mean. So it's just a suggestion how we can get this across to all frontline facing staff as well.
Well, I think that's certainly, thank you, Tillon, that's really helpful. I think one of the things that, I sort of alluding to is you may want to take this not just to your senior leadership place in your organisations, but actually, for a lot of people, they probably don't yet know really what is system working. They'll only really know that when they're involved in a pathway or involved in something where they're working directly with partners. But I think this could go far and wide. The signature bit you mentioned is interesting. I think that for the actual main document, when we're signing it off, we're going to have everybody signing. And in fact, there's a table there for that. I feel a little bit sort of not sure about me having a signature on the thing, but I guess if everybody's signed the main thing, the small one is too small to have everybody's signature. So I probably will have to do that on our behalf, but I'm keen that we're all engaged absolutely in this. So I think that we get the sense of good support for this. We need to make it live and breathe. We need to use it. And as Richard has very carefully pointed out, and I think frontline as well, as Tillon has said. So if we're happy with that at the moment, please do take it formally to your key places. And Adele, I know you'll probably want to say something else as well. Go ahead.
Thank you. Yeah, just to follow, I think from my perspective, I would still want to beef it up a little in terms of the sort of relationship with the voluntary sector and also the relationship with our communities. Really welcome that commitment to tie in the way that we work to our understanding of what are the drivers of the wider determinants of health. So much happens outside health and also care services. So really welcome that aspect of it, and the commitment to work together and those ways of working. And I think when we go out I do want to take it through our governance process so that it has that real scrutiny and challenge right across through the organisation with real transparency, because that really aids and strengthens it. Obviously, it makes it something everyone's buying into. But I think as we go out and talk to the city about it, it's got to be a genuine conversation, and it's not just about what we do between ourselves as sort of components of the system, but also how we, I guess, lead the city into the sorts of ways of working, the big players in the city, not just the really obvious anchors, but thinking about how they can support a health city in terms of employment, in terms of our local environment, and really between us providing sort of collective leadership for that, but in a way that's really listening to citizens and understanding the challenges and co-producing with our communities who are challenged in terms of their health and well-being. So definitely supportive in principle, want to take it back through formal governance in the council, but I think overall it's a good document.
Thank you, Adele, and would welcome your thoughts when you've been through that process and beefing up. I think we all have to keep in mind the citizen, and the story we've just heard around the vaccinations just reminds us, I think, absolutely about that. So that's great, fantastic stuff. I'm going to take that as if we're not core 8 today, obviously we can't really make any decisions. But however, I think we get a sense of good support. So appreciate that and the work you've all been doing on it. So I'm going to move us on to another important thing, and this is something I'm really pleased to see here today, which is the ICS Outcomes Framework, which is something that's been in place in Nottingham and Nottinghamshire for some time. And we're very keen to see this brought back alive, really. And we've got really in two parts, and I'm going to ask Amanda to kick things off, because this is going to give us a sort of baseline, but I think we also need to offer some support or otherwise to some particular areas that we'll do. We can't do everything all at once in this area, but to get something going that we can measure and see the progress, and at places, when we come on to discussion about place, you know, we'll see how places can feed into this and start to move the dial on some of these vital areas. But everyone's had the paper, obviously, but Amanda, do you want to just introduce that properly?
Yes, thank you, Kathy. I will do. So as Kathy said, this is about how we bring the outcomes framework to life, and partly how we actively monitor it and use it as an improvement tool, but also how we embed that into some new ways of working to improve outcomes, but also use it as a tool to drive some transformation in terms of what we're really focusing on. So the first paper is essentially it's a baseline stock take, and the aim of that is really to familiarise the board with our current position, recognising that some of the data does take a while before it gets through the sort of validation and publication processes. So it can seem relatively a little bit out of date. But also it is really important, I think, visually it does highlight the levels of inequalities that we have in our communities. The work, we have continued to drive some work around the outcomes framework during COVID, particularly around diabetes, frailty and mental health. And we have linked that to a population health management framework, and we have used that to inform the development of our health inequalities strategy as well. So it hasn't been lying fallow, but this is really now a real push to the next stage to really incorporate it into practice. There are some areas of concern, as you will see, that the data do show us. In the city, there are areas, things like the levels of violence, homelessness, air pollution, and unemployment in the county, and obesity, alcohol and smoking across the board. And these are all, you know, areas that have got a very significant impact on health and well-being. So we do need to now move to the next stage of understanding how we're going to embed this in our sort of everyday thinking. We're proposing in the paper that there is a quarterly review. These things don't, you know, move immediately. And we align that to how we do our overall performance oversight as well, so that's a very much more embedded way of working. So for the first paper, that's what we're asking the board to agree to. And then for the second paper, sorry, Amanda, yeah, do you want to stop there? Yeah,
let's just do that first. There. Yeah, we've got some clear recommendations for the board. So with that in mind, I've got Hugh and then Richard Mitchell.
Thanks, Hugh Porter, GP and lead for Nottingham City ICP. Really welcome this. I think we really need to use the outcomes framework. We've had it for a while, but I think we're not maximise it. There was 2 points just in my head, Amanda and Kathy. One is it absolutely highlights the inequalities, but for sometimes with frontline staff and organisations, it can feel like a bit of a performance tool if you see all those reds and it's not sort of shifting, and it can be quite sort of disheartening. So how it's used and how that's phrased is really important, because you say it can be really tough for people if they can't see the dial moving it. All they're seeing is my place has red all down it, and it's a real challenge. And the other thing that just struck me a little bit, we may need to think about thinking about sort of conversations with citizens and local authority. Obviously, there's very much a sort of focus on sort of strength-based approach, particularly in sort of social care. And if you look at sort of key outcomes of health, well-being, independence, it almost feels like our citizens are perhaps fractionally passive in some of that wording. So you don't get that sense of trying to transform our system into our citizens being strength-based. So there may just be a little bit of nuance, but most of that is quite a passive thing, doing to our citizens rather than doing with and enable them. There may be a little bit of work on that one, but otherwise very supportive. Thank you.
Thank you, Hugh. And I really like that point you made about the citizens and the active. I think we're all on a bit of a journey here. Some of you are further ahead than others of us, I imagine, and I'm hearing that really. But I think that's something, Amanda, for us really to pick up is the language around, you know, the active citizen rather than the passive citizen. So that's really helpful, Hugh. Can I pick up with Richard Mitchell now and then John Towler?
Thanks. So I think 3 points from me. So again, support it. 3 points. I counted. I think we've got 51 or 52 output measures. That's a lot of information. I think there's a bit about the prioritization, or really trying to identify what is it telling us, because I suspect we would all interpret it in different ways. The second point, I know it's in the paper, but some of the lag times around receiving the information are huge. The obvious one being the percentage of the population exposed to road, rail and air transport noise or more during the daytime. The last period was 2016. I'm not sure of the validity of reporting information that's 4 or 5 years out of date. And I think if we had more information, it may move some of those reds to green. So I think there's a bit about identifying the maximum lag time that we're willing to accept. And simply if we can't get information, say within 2 years, I'm not sure it's that useful. And tied into that, the bit about reporting quarterly, if it's taking 5 years to get information, reporting on a quarterly basis, that information isn't going to change for 20 quarters. The final bit is, I'm probably unsighted to it, but if as an ICS we're not taking specific actions that we think will change an output measure, do we think it's important that we're reviewing it or looking at it? So for example, and this may be my naivety, if we're not, say, for example, collectively doing stuff around pupil absence, is that something we should be looking at? It may well be of sort of real interest and provides the context, or it may not be. I don't know the answer to that.
Okay, thank you, Richard. I think, Amanda, these will be things we'll want to talk about, but this is kind of getting us back into the real thinking about this. And I completely agree with you about the time lag on some of these. And we'll feed back to Sarah, who's been doing this work around that. The speed of movement, again, I agree, but I think the second paper in terms of what can we focus on is trying to help us look at, are there some priority areas? And so there's a lot more to do with this, isn't there? But that's really helpful comments there. John Towler.
Thanks, Kathy. So it feels as if we've been stuck on this for the last couple of years. And I've been a big proponent of the need to bring it to the fore. So I think most importantly, what I wanted to say is that I'm hugely encouraged both by the progress we've made to populate the framework. It's absolutely not perfect. I think Richard's points are valid, but it feels as if today we're a lot further forward than we have been for the last couple of years. And then actually, I suppose just a comment about Amanda's second paper, the fact that we're able to identify areas for its practical application feels like a big step forward too. I guess I'm concerned about the analytical resource that we need if we're to take it to the next level. And perhaps, Amanda, you could comment just or give me some assurance around that. But most importantly, I just wanted to offer some positive endorsement on the progress we've made.
Thanks, John. Much appreciated. And it is a work in progress. But Amanda, do you want to follow up on the resource or indeed any of the other comments? That
I will do. Yes, I will do. Thank you. So I think I agree around we need the strength-based approach, and absolutely in the sort of work we're doing around embedding this in particular care areas, they are very much a strength-based approach to the sort of care design and transformation. Richard's point about prioritisation, I do think there's a bit more we can do, Richard, in terms of what you see quarterly, and there's some, I think I think it's very valid points, and I think we should take that away and do that, so that what you're looking at, you kind of know what the point of it is and which bits are more important or less, so we can do that. The analytical resource, we are realigning some resource to make sure that this is the focus, so that's not an issue.
Good. And ultimately, my dream is that as places are working out their programs, and I know that's in development at the moment, what are your priorities? How will the delivery at place start to change the dial on this overall framework and these outcomes? I think that would be the dream place, isn't it? That we can see the connection between the work that's done and the improvements that take place. But I live in hope there on that one. Adele, and then Tracy, and then I think we'll close this item.
Yeah, thank you. I think I've just a few observations really. One, just to come back on that sort of time lag issue. I can see what you're saying there, but I think we still have to make sure that we hold on to what the core sort of outcome we're looking for there, which you know, in the space of sort of clean air and all the implications of that has for our citizens. So I wouldn't want us to ditch the long term, because it's you know, some of that is the most important things for our citizens. We increasingly understand the long-term effects of that, and I wouldn't want us to lose the driver within the system for us considering, you know, how we work as trip generators and so on. So you know, and all of the things that we could do to support active travel as a system. So just an observation there, I wouldn't want to lose that. And then just also in terms of sort of outcomes output, so we're counting, unless I have this around my neck, it looks like we're, and is there an intention to are we just intending to use a sort of ballpark, you know, which we do have the data for that, around healthy life expectancy to be the measure of this? Because I think what you'd almost want that to be disaggregated, so that you're counting the detailed outcomes on all of those rows, so that, you know, so instead of saying how many, I'm struggling to read the papers. I've got struggling with my glasses. So instead of kind of how many interventions have we made, but how many people have stopped smoking? Because, you know, we talked earlier about learning from our citizens, and, you know, and Kathy made the observation of, you kind of, you know, now we know that if you go to citizens to give them to make services easier to access and so on, but I think if we'd asked citizens, and certainly we knew as a council, you know, they would tell you that makes a difference. Likewise with things like smoking, people don't smoke because they smoke because they're stressed, they smoke because they're hard up and they're worried sick. So, you know, counting an intervention is not going to help us that much. It's useful, but it's not. So I'm assuming that. Well, I'd just like to know, is there a plan to count outcomes in more detailed ways? And then just one further, just coming back on that point around analytical resource, absolutely. It is sort of newly bringing public health into my portfolio. Really interested in the ways that our public health colleagues can help sort of drive that understanding of the data and help us work together and kind of really mobilise the JSNAs in ways that we haven't previously as a system. So sorry, it's a bit of a ramble, but be really interesting further discussions on that.
Absolutely, and I'd like to capture from that, Amanda, Rebecca, the public health bit. I think is really important. You know, we haven't, Jonathan's not here, for example, today, but the public health bit is critical. You've heard me say before, the JSNA is an underused tool and piece of information, and lots of information, and I do think we will be expecting to go into much more detail. My sense is that one of the good things about Nottinghamshire is we have a lot of data, and we now need to use it really, really well. So I would support all of those things. Amanda, have I said anything that you wouldn't want to agree with?
No, agree. And the way we've worked in the data cell during the COVID, I think is a model for the future, and that does bring together public health and health sort of analytical expertise. So I think we will continue to mirror that, Adele, and build on it very much so. And yes, we will be looking, we'll probably pick some specific areas. And I mentioned earlier diabetes and frailty, for example, where it's very much under the skin of what constitutes that healthy life expectancy and what morbidities people have. So we'll have to do it in stages, but that will be very much how we work, and then we'll have targeted interventions.
So I think what you're seeing today is the tip of the iceberg. It's getting it back, as John has sort of said, getting it right back onto the agenda. Tracy, you're going to get the last input on this one, and then we've got the second paper to do as well.
Thanks, Kathy. And actually, Adele said that a lot of what I wanted to say. I think we have to keep our eye on the longer term. And it was just to support what Amanda was just saying. We did have the conversation at the executive group around the sort of time lag on this data, and requested that we looked at some more detailed indicators that did sit underneath these rows, so that we've got some sort of sense check on whether we're making progress to shifting that dial. So that is absolutely the intention. But the last thing to say was, I really do welcome the focus on children and young people in this document, because I don't think that we've focused on that in as much attention as we probably might have done over the past couple of years. So really do welcome the children and young people focus in here. Thanks, Kathy.
Thanks, Tracy. So just for this paper, can I, just for the formal notes and everything, we need to note the progress on developing and implementing the ICS System Level Outcomes Framework. I think we can do that. I think we've noted that there has been good progress made, but we also know that there's further to do. So I think we need to add that to the note. And we've looked at the baseline, and we can see there that there's some areas of concern, but I think, as Adele has pointed out, we need to break that down into much more detail as we go forward, and Tracy's supported that. And I think in terms of next steps, that sort of drops out of the discussion we've had. We'll want to make sure we have this at the right frequency, we've got the right detail, and we need to prioritise. And I would just like to add that we do need to link it through into the place working, but that will develop as we go along. Is that okay as summary on that? Everybody broadly support that. Amanda, do you want to just take us on to the second paper, which gets into a little bit more of the specifics of how we will use this? And I think Tracy's already touched on one area, so that's good.
Thank you. Yes, so as you say, this paper proposes 3 transformation priorities to embed the outcomes framework and also be really ambitious about new ways of working and the level of integration as well in the provision of care, but also the enablers around it, such as pooling budgets and other things. So it is quite a significant, I call them signature areas that are signalling new ways of working that we want to do in the future. So the 3 areas are community care transformation, very much with a focus on the integration of community teams, children and young people with a focus on mental health, complex health and care and placement needs as well, and person-centred commissioning, which is, it covers off things like continuing healthcare, home care, and other individual packages of care. And that has been, I think there's also transactional activity that happens between health and councils around these areas, which doesn't really add value. And so we're proposing a very different and very strength-based way of working around those. So we're asking the board to support these 3 areas. In each of the 3 areas on the kind of plans on a page, you'll see the proposals at the bottom to further develop more detail around these areas and work those up in Q1. But we're asking for the board's support to take that forward, really. Thank you.
Thanks, Amanda. Key areas here, we clearly can't cover everything, and we have to pick out this business of prioritising is always a huge challenge, isn't it? And we feel we have to do everything, but these 3 areas, and I'd be interested to know if those of you who are predominantly working at place can see how you might feed into this, and are these important, because that's actually where the stuff's going to happen. It's not so much at this level. Hugh, I was glad you came in there. I could see you launching onto your
Yeah, no, oh, absolutely. I mean, I think these are real opportunities in you to put that question about place. And I think, if I think of community care transformation, a place, and I'm sure my other place colleagues will agree, we're doing such a lot with our PCNs. There's a huge opportunity. We're just doing a bit of work in the city to turbocharge some of our PCNs around that integration sort of component. That's almost like a bottom-up meeting this top-down. So I think there's a real opportunity. And I agree with Tracy, the children's and young people, Nottingham was an early intervention city, but I'm not sure we've been doing enough early intervention for quite a long time. And I think particularly, post-COVID and some of the effects it's had on some of our families, I think it is really, really important long-term thing. So I think actually this fits really well with a lot of the place-based sort of way of working things, because it is involving that much broader thinking and broader sort of linkage with our sort of communities to make a change. So very, very supportive, Chair.
Excellent, thank you for that. They feel like good areas, don't they? Amanda, is there anything you want to say about that? I think I just took good support.
No, agree with that. Yeah, agree.
Alex.
Yeah, and just to echo what Hugh says, these feel like really meaty, chunky areas that will make a real difference to our citizens. And they're also really meaningful areas that we can do some really good citizen engagement with as we develop those plans, and do that in a different way, working as a system in a much more joined up way to hear from our citizens in creative and different ways. Again, maybe drawing from some of those experiences of the vaccination. So I've asked my team to start to think about how we can apply our statutory and non-statutory duties around patient and citizen involvement in a bit of a different way on these 3 programmes as a bit of a sort of test bed for how we might do that going forward, working together as a system. So I just wanted to let the board know about that.
Fantastic. I'll take one more on this. Eric.
Thanks, Kathy. It's a parallel conversation. It's something I wouldn't want us to lose track of, because these are absolutely fine, absolutely sign up to them. But looking at it from a patient point of view, remember the public point of view, one of the things that they're going to be looking for in the next 12 months or so is to restore access that they've not had in the last 14 months. And I include that in its widest sense. So it's, restoration recovery, I know is on everybody's agenda, and it might not be for here. But there's also things like, how do we restore access to mental health services, community services, to GPs? And I think if we're looking at it from a population point of view, I think that's probably the forefront of many, many people's minds. How do they get back to the access that we've had to curtail in the last 12 months or so? Because it might not be an item for this paper, but I wouldn't want us to lose track of how important that will be to, the man and woman on the street.
Absolutely, and Amanda, you might want to say something about that, but I think there is no shadow of a doubt that in terms of things that this system has got to do, that is absolutely right up there, isn't it? I think these are the things, though, that will be done, in addition, shall we say, because we can't just do one thing, but we do have to do that. Is there anything that you'd like to add to that, Amanda?
No, I was going to say it's as well as, not instead of. And some of this might support access into some of the services.
And I'm sure we'll have a discussion at a future meeting about where we are on that recovery and as a system, how are we doing that and what else can we do? One of the things I quite like about these is it strikes me that they are things that are beyond health. They're very much, to be honest, the children's agenda is predominantly in local authorities. They spend a lot of time at school, don't they, apart from anything else? They are not in health. So I think that there's a lot of lap over here, and health and well-being and so on is all good stuff. So I take it that we're broadly supportive of these. We note Eric's concern to make sure that we don't let recovery slip off the agenda anywhere. And so I think the thing we're asked to do is to agree really the proposed transformation areas and to trial the approach to embedding the outcomes framework during this year on these areas. I think that seems to have support. We may not be correct, but again, we can bring that back, but support is good. So thank you for that. terrible chairing. Of course, you knew I was going to slip behind, but never mind, we'll get there. The next item is, and thank you for producing a joint report this time on the ICPs or places. I think we've got Hugh, John and Richard are joint owners of this. I'm keen, as you know, to hear in the future around the local authority input on the place as well. I'm happy for you to present how you wish today. But I think as I keep talking about place, you will see I regard it as the engine room for our work. And here as an ICS, we're here to support what you're doing and all the colleagues across the places. But can I hand over to whoever's kicking this off?
So I haven't rehearsed this, but I guess I'll start off. Then John and Richard may want to come in. I'll try and be quick, Chair, because I appreciate the timings and I wanted to catch up some minutes really. So I'll assume everybody's read the paper. There's about 2 or 3 things I just wanted to highlight. As you can see in page 1, the ICP in the city has been looking at its sort of current 5 cohort-based priorities. These are around cohorts of our citizens. They've been running for about a year, so we thought it was a good time to have a little look and are they progressing, are they delivering? As you can see, we've agreed to continue all of them. Some of them need a bit of changing, tweaking. We're learning as we're going along. This is a learning process. Importantly, you've got to keep your fingers crossed today, because for our supporting people with severe multiple disadvantage, we're putting in our Changing Futures bid today to MHL-CLG, so keep your fingers crossed that one, that they approve that side of things. The most important thing, I think, is item 7. So because we're a year on, we also repeated a conversation through Health Watch and with the CVS as to priorities for our citizens. So we did this at the sort of start of the ICP. We thought a year on, obviously they were different world, really useful to have that conversation again. So thanks for Health Watch for helping support that and CVS. So I recommend people having a look at Appendix 2. Really important to listen to that sort of citizen's voice, and I think some quite important feedback, as you can see in item 8, and some of the challenges around mental health, BAME health inequalities. Quite a lot of concern from the CVS that actually, you know, they've had a really difficult challenge through this pandemic. You know, we're putting a lot of processes in place, like social prescribing link workers, but actually, you know, what are we doing to support the voluntary sector to receive the patients we're sending to them? So it was quite an interesting message to come from them. I think it might be worthwhile at some point we're thinking whether we have Health Watch have a conversation with us at the board, because I think there's a lot of learning there. And as you can see on the back of that, we're adding a new cohort-based thing around mental health and well-being, because actually that's such a strong theme coming out from our citizens at the moment, that we thought actually we need to sort of build that in. Hopefully it fits with some of the thinking of the work the ICS wants to do as well. So I will leave it there and say I'm happy to take questions from a city perspective, but I'll hand over, I guess, to, is it John next?
Yeah, hi, thanks, Steve. Hopefully you can hear me, everybody. Good afternoon, John Bruin, Chief Executive, Notts Healthcare. And I was looking to see, here's some frowns. Can you not hear me very well?
It's just a little bit of an echo, but if the rest of us make sure we mute.
I'll be very brief. I'll take the paper as read. Lots of synergy with what Hugh has just said. We've been prioritising our work with the district and borough councils, developing our multidisciplinary teams across health and social care. And we've also had some really powerful community voice events with 60, 70 people from the CVS sector contributing to discussions about our forward plan. And it sounded so bad, I'll leave it there in the respecting time as well, and hand over to Richard. Thank you.
Thanks, John. I think it's really interesting to see how the 3 ICPs are developing. Obviously, there's a commonality between the 3, and there's also some differences, and I think those differences can be really positive as well. Like Hugh and John described through our paper, we've tried to be able to evidence that thread that runs through the work of the ICS, the work of the ICPs, then our statutory organisations and the voluntary sector. We've listed our 2020, our likely 2021-22 priorities, and they're coming back to our public ICP board 2 weeks today. And then finally, I was reflecting on something that Eric just mentioned sort of a minute ago, or I interpreted about sort of stakeholder management. And it struck me, whilst those 7 priorities that we have listed are of importance, and it's difficult to disagree with them, if we think about, say, in the health world, NHS England and NHS Improvement, what they're looking to us to deliver, or possibly what patients or citizens or communities are looking for us to deliver, there's some really other important things that we mustn't lose sight of. So obviously we've got a huge responsibility for delivering the money. We've got a huge responsibility for reopening our services, improving access both across health and across care. So my point, I suppose, is those 7 priorities are important, but there's a whole range of other things that we need to be focusing on that gives us the that over a period of time will give us the accountability and the autonomy that we all would really like.
Thank you. I think we've time for probably one question or one comment on this. So, but before we do that, I just want to say, well done on all of that. It sounds as though you're really, cracking on with ensuring you know what your priorities are. I see as well within the papers you've done some maturity assessments and so on and so forth. I think where I'd quite like us to get to as well is in future, well, not necessarily immediately, but in time, having some data that shows you where you're going at place, as well as across the whole of the system. So I think that would be an ambition, is what are the things you might be measuring that will help everybody understand the progress, and therefore in our role in the ICS board, what help do you need from us? And in a way, that would be my question right now, is what help do you need from us? But I'll let you think about that while bringing Claire Ward.
Thanks very much, Kathy. And actually it's a question for Hugh, and I noticed in the report the workshop that you've been doing around the ICP and the Health and Wellbeing Board, and I wondered if you might share some of the outcomes and the learnings that you have from those workshops, the one you've had and developing ones across the system, so that actually we're starting to understand the synergies between health and local authorities, which clearly exist, and the work that has been done around working together on COVID, so that we can actually build and learn across the system some of that understanding.
Absolutely, if I can come back, I'm very happy to share that. It's been we've had 2 workshops which have been really interesting, because as you say, there's such a lot of overlap, and actually we're trying to think about aligning the governance as we go forward. We've got another workshop probably in June, and I know I'm working with Rebecca and Amanda looking at the ICS development session, and in terms of that place, so I'll happily sort of feed that in. We can perhaps bring that into that development session, but also happily share some of the learning outside this meeting, so you can see what's going on, because there's no secrets to that. And I say replicating, there's definitely things we can share and learn together.
Thank you, and we'll look forward to that. So I think I'm going to thank you for the reports there. I think we'll want to develop this further, and in due course I probably want to move this higher up the agenda as well, so that we spend more time at the beginning on our place discussions. But thank you for that, great stuff. Can I move us on then, Amanda, to the next section on assurance, integrated performance and finance reports, I think next.
Yes, thank you, Kathy. I was just going to give a brief sort of overview of some of the points in the report for the board, and this is really sort of a year-end sort of summary, really. So I wanted to highlight a few areas. I think there's been a mixture of excuse me, really considerable achievements and also some challenges. So the vaccination programme we spoke about earlier, we actually have done, I think, comparatively very well on the restoration of services, but there is, as Eric said, a lot more to do on that, and it will be at front and centre of people's minds as well. And then a key sort of priority around looking after our staff, and particularly around some of the workforce offers the extreme pressures that people have been under during this year. So there will be a sort of a developing sort of collaborative working around workforce and workforce wellbeing. and making sure also that people who live in Nottinghamshire do receive the best possible care. So those are sort of core areas, if you like. We have developed plans for the first half of the year, which, as you know, is very much in line with the COVID regime that we've been in during the previous year. And the second half of the year, we'll have some different business rules associated with that. So we'll be very busy, I think, over the next few months developing those plans. And we're also developing our plans to respond to the legislative changes as well. And that's, very significant in pending the legislative changes that we will need to adapt to thrive in a new legislative framework, and most importantly, serve the needs of the people who live in our areas. With that in mind, we have established a transitions and risk committee across the system, and a number of work streams, quite significant work streams within that, including the CCG transition, which if the legislation goes through, the CCG will effectively be dissolved, and there will be a new statutory ICS body, NHS body. There will also be a statutory partnership, health and care partnership, which gives us, I think, some real opportunities there. And so we'll be dedicating some efforts into that as well. The development of places, the development of provider collaboratives, and then the governance that sits around the new framework, as well as continuing with our OD journey and our sort of how we work with stakeholders, as has been discussed as well. And then last but certainly not least, I wanted to mention the development of clinical and professional leadership as well across health and care, embedded at all points of our system working. Very pleased that we've sort of got the approval today for those three key areas. I think there's some significant opportunities around transformation in that and other areas. Just a little bit of a look back. We finished the financial year, so the NHS partners achieved the financial requirements that we are asked to do by the regulators, but we do have a very, very challenging underlying position, and we will need to address that for the second half of the year when the business rules change again. And we can see from the report that our council colleagues had variances in the social care positions within the overall council budgets, with sort of some negative, some positive variances around that. And again, with COVID, recognising the unprecedented pressures in that in social care, and very grateful for colleagues for the joint working that we've done. We are also, just finally, I wanted to highlight that we are reviewing how we work with regards to performance, and obviously the role of the ICS will develop over time in that regard. But our proposal is that we have a performance group which will deal with the detail, the operational detail, that will escalate issues up to the system executive group, and then the board here will have oversight of key areas and concerns. So we're proposing to change the way that we sort of bring performance to the board, so that the board is truly exercising a kind of an oversight role. So thank you. That was the things I wanted to highlight.
Thank you. Thank you very much. I think that last point that Amanda's just made about how we deal with this at the system level, I think that does need to evolve, doesn't it? Because we could spend ages now going into each element on the system delivery dashboard, but actually that we can't. We don't have the capacity to do that. I think when we've got our governance more substantially in place, we'll be able to receive exception reports, really, which I think will allow us as a board to understand where we really need to put focus or make any changes. But thank you for that, Amanda. Thank you for the update there. Any comments in particular to Amanda on any of that? If not, let's accept that report. Thank you very much. I see we're on to the last thing, but I'll just note that attached to the papers, there is a report from the King's Fund, which if you haven't read, I commend it to you. the system features within it. We were part of that, and I know we've had sessions in which some of you've obviously had discussions, but it's a useful document, and nice to see the number of times that they quote our system and what we've been doing. We always like to see ourselves in print, don't we, from that point of view. So that's good. And then finally, really, is for us to just think about, review the meeting against a partnership agreement. Just have a little think about that. But the other thing I was going to say is I do want to move to us being able to have questions from the public at these meetings. So offline, we'll work through that, Rebecca and Amanda, how we practically do that in this virtual world. But I certainly think we should be doing that one way or another, because that's the purpose of being available to the public. So I'll pick that up with people. Partnership agreement. So we've just sort of broadly supported it. Have we conducted the meeting largely in line with that, you know, with openness and honesty and trusting sort of way of behaviour? Any comments from anybody? I'm going to take that as largely okay. Tim, though, you're going to come in and help me.
No, just to say, I think we're all maybe sharing your pain at the speed at which you're having to chair, and openness is perhaps restricted by such a speedy meeting. And I wonder if we just ought to, if we'd had the usual 3 hours, we may have been able to be even more open than you've allowed us to be.
Yes, I absolutely think that's a very, very good point. We will be meeting next week to discuss the next meetings and so on, and how we get the balance of things. I think we might need to adjust the start time. I think there were particular reasons relating to one organisation that couldn't manage earlier, but we may have to look at that. I agree. Thank you, Tim. Richard.
Yeah, Tim's pretty much made the point I was going to make, which was I think it's an hour and 10 within that limited period of time. There's a lot to get through, which I think we've had a really good conversation in places, but it sometimes reduces our ability to disagree. I think the organisation that has meant we can only start this time is Sherwood, because we have our public and then a very short private board on a Thursday. I'm sure with Claire, Ward and I, if that's a problem, we can try and move our board if that would make things easier. So possibly a longer board would give us an opportunity to sort of review the way in which we've behaved in line with that the agreement earlier. I suppose my other point is, as someone said earlier, I don't think it's so much about the way that we conduct ourselves in board, but I think it's the multiple meetings and committees that surround this, then certainly the way that it infiltrates to all our organisations. And I think we need to think of a mechanism about how we can sense check that. I'm confident that whether it's an hour or 3 hours that we spend together, I think we'll be okay. It's everything else that I think we need to keep an eye on.
I completely agree, but I think it's important that we do it too, because we need to lead by example as well. But I absolutely take the time point. In fact, that's a really helpful comment, because I'll try and push that along, and if we can liaise with your organisation, I'm sure that would be helpful too. Good. Well, thank you everyone for that. That finishes the meeting in